sign. So today, last week we did something on uterine fibroids, and Dr. Randolph Baah took us through a whole lot. We gathered a lot of information, and so by now I am sure we are so much equipped when it comes to this topic, and we want to thank him so much. He's back today. In fact, a lot of people kept telling me, Lena, can you bring a doctor on once again, because we think that there are a lot of things embedded in him we need to, draw from. And I spoke to him, and he didn't turn deaf ears to that. He's here today. Of course, we are not going to be discussing fibroids, something else, a brother or a sister to fibroid. So that's what we are going to be treating today. And I want all of us to pay particular attention. I want us to, at the end of the day, benefit like we benefited last week. And so we are going to be talking on endometriosis. And Doctor is the senior gynae at SDA Hospital Kwadaso in Kumasi. Yes, that is where you can locate Doctor. So if you have any gynae issues, you can contact me, and you would also get in touch with Doctor. Even though he is on the way, he still has tuned in today, and he is going to be with us. Doc, how has your day been?
Thank you very much. Well, it's been busy.
I know.
Yes.
We thank God.
Yes, sorry, I'm late. I have to pet in some corner to be with your audience.
That's okay. They can understand that. Once you are here, we are fine.
Okay, thank you.
Okay, so let's roll.
Okay.
What do you have for us today?
Yes. Once again, thank you for the opportunity to share with your audience. And let me take this opportunity also to welcome your audience to the show. We are grateful that you are here to listen to us and to share ideas. Today, as you rightly put it, we will talk about a very interesting topic. Actually, it is a topic that affects about 10% of all women on planet Earth. But unfortunately, very few people know about it. And the complications and the consequences of this particular condition is daring. And a lot of our young women, mothers and sisters are really suffering from it. So the topic today is endometriosis. So we will talk about what endometriosis is. Basically, endometriosis is the implantation of the endometrial tissues outside the endometrial cavity. Let me say it looks a bit confusing. Somebody will say confusing. Yes, it's a bit confusing. All what it is that, if you take the woman's uterus or the womb, okay, where she bleeds every month or she sheds, as we call it, every month. That's the inside. So it's like, you can consider it this way, like in your room, you have a wallpaper there. So every month, you sort of remove the wallpaper and put a new one. So that is what happens during menses. So during menses, every month, the endometrial tissue or inside of the womb is shed or is removed, and a new one is built up. Now, when this process happens, for some reasons, some of these cells, they sneak and get implanted in the other parts of the organs. And these cells are supposed to be inside only the endometrial cavity, meaning that it's supposed to be only inside the womb.
Right.
Now, when they are implanted outside the womb, it can be on the intestines, it can be on the ovaries, it can be on the fallopian tubes, it can be on the pelvic floor. Some can even go into the brain.
Wow.
And so we have something we call catamania epilepsy. There are some women, every month when they are menstruating, they get seizures, like epilepsy. So what happens when these cells get implanted outside the endometrial cavity, that is outside the womb? What happens? So what happens is that these cells, because these cells are hormone responsive or hormone dependent, what it means is that everywhere that these cells will be implanted, every month, those places also menstruate, just like inside the womb. So, and in the process, there is inflammation and activation of a certain hormone called prostaglandin. I mean, prostaglandin is what causes the womb to contract or to squeeze, so that when the inside is shed, the flow will come, what you see outside as blood. Right. Now, because these cells are hormone dependent and they are hormone responsive, and they are behaving everywhere as if though all those parts that they are menstruating, you have this generalized or systemic response of prostaglandins. So a lot of prostaglandins are released, and then there is sort of systemic or generalized contraction, and which causes the severe pain. So you realize that there are some women who, right from onset of menarche is when they started menstruating, they always complain of pain. And some is so bad that even when we were in school, you realize that some of our young ladies or our classmates, when they have their menses, they can't go to class. They have to be staying in bed. They don't want noise. They want to be left alone. They are in excruciating pain, and they suffer a lot. It is most of them, majority of them are due to endometriosis. So this endometriosis causes this severe pain. And also it causes pelvic adhesions. So what happens? You have what we call dysmenorrhea. That is the pains associated with menses. It is very common. And in our local parlance, I'm sure you all heard of enidania. And normally our parents' advice is that, oh, when you get pregnant and you deliver, it will stop.
It will stop.
Why are they saying this? They don't have any scientific evidence, but they have what we call observational evidence. They have realized that as soon as the woman gets pregnant, they then suffer from these pains, and sometimes when they deliver also, the pains goes down. Now what happens? Because pregnancy takes about 10 months in our calculations, but 9 months in the calendar. So when you are pregnant, for that 9 months, you will not menstruate. So you'll be relieved of the pain. And then when you deliver also, remember those days, our parents used to do exclusive breastfeeding. They will feed exclusively for more than 6 months, and also even continue breastfeeding for about 2 years. And you know, when you are doing exclusive breastfeeding, it gives you a contraceptive effect for about 6 months, the first 6 months, so that you don't menstruate. And once you are not menstruating, it means that those endometrial tissue that have been seated outside the endometrial tissue are also not bleeding. And so the pain and the prostaglandin and all that are in quiescence. What it means that they are not releasing. So you are relieved from the pain. That's why our parents realize that when they get pregnant, these symptoms seems to be relieved, and therefore they encourage the young ladies to get pregnant and have children so that they'll be done away with this. Now, so the first symptom is dysmenorrhea, severe menstrual pain. The second thing is dyspareunia, that is pain during sexual intercourse. Now, I have, and I know a lot of young ladies and beautiful young women whose marriage has even broken down. When they see their husbands, they start shivering because of the sheer excruciating pain they experience during intercourse. You know, intercourse is not supposed to be painful. And so when you are experiencing such pain, certainly there's something wrong. And one of the major causes of this pain is endometriosis. This same endometriosis can be seeded on the bladder, so that when you are urinating, it's so painful. Or sometimes you can even urinate blood, because as we said, that everywhere that these cells are seeded, every month cyclically they bleed. And so when you are bleeding it's on the bladder and you are bleeding, you bleed into the bladder and then urinate and you may see blood in it. And then it will also cause pain and inflammation. Also, it can also cause constipation because some can be seated also on the rectum and on the intestine. And sometimes you have what you call dyschezia, painful on passing stool or blood in the stool. All these ones can be due to endometriosis. And there are also others who experience chronic pelvic pain. They always complain of lower abdominal pain, as we hear myalgia, waist pain, chronic lower abdominal pain. This also can be due to endometriosis. And one of the grievous consequences of endometriosis is also infertility. Remember, I said that about 10% of women suffer from this condition. And out of 10% of women who suffer from this condition, 70% of them also suffer from infertility. So because of the endometriosis, yes, the endometriosis can be seated on the ovaries, meaning that it can take all the ovaries and then you develop what we call endometriotic cyst. So when you open it, the cyst is like chocolate, dark fluid in it, because that's because the menstrual bleed that has undergone oxidation, and therefore it has turned into like dark like chocolate. So we call it chocolate cyst. And so when you have endometriosis cyst, what it means is that the ovaries have no healthy tissue to be able to produce the eggs that you need so that you can get pregnant. Aside that, also because the endometriosis causes systemic inflammation, and so there is inflammation on the fallopian tubes, there is inflammation on the uterus, there's inflammation on your intestine, and therefore they join, all these things are joined together, and so it pulls your fallopian tubes. It can cause blockage or kinking, so that when the eggs are picked, it cannot be transported to meet the sperm, and therefore infertility is one of the major issues. Now, why is it that this is such a major problem, and yet even doctors and nurses and the general public are not so much aware or don't talk about it? Because diagnosing it is very difficult. It's very difficult to diagnose. And so there are a lot of young women who are actually suffering from endometriosis, but all what they know is that they have dysmenorrhea and adenomyosis. But what is causing the adenomyosis, they don't know, and therefore they are not getting treatment. So how are we going to control this endometriosis? The first point is getting diagnosed. And as I said, diagnosis is often misdiagnosed because most of the times they will treat them for PID, saying you have pelvic inflammatory disease. They will treat them for UTI, urinary tract infection. They will even treat them for ulcer and other things. Some will treat them for bone because they'll be complaining of lower back pain, and they will treat them for radiculopathy, lumbago, and yes. So that is where the pitfalls are. And so the first point is getting diagnosed. And getting diagnosed means that you need to see a specialist who has special interest in women's health. And therefore, when you go, they will listen to you, take history, examine you, and then also make a diagnosis so that the treatment can be done. Now, how are you going to control this endometriosis? Now, remember, endometriosis cannot be cured. Before we go there, let me say this. Some will say, how does it happen that even these cells even get out from the womb and therefore get implanted in all these places that we have mentioned? So what happens is that, the fallopian tubes, they open into the abdominal cavity.
Right.
And so we have what we call retrograde menstruation. So what it means is that as you are menstruating and you are bleeding, or what we call you are shedding, some of the blood that is mixed with the tissues, they flow back.
Okay.
And it flows back through the fallopian tubes, and therefore it spills into what? The endometrial cavity. So this is how come these cells are able to get access to the endometrial cavity. Because if not, somebody will ask, why? If I'm bleeding and everything is coming out, how come some are able to get implanted in my brain and all that? I'm also sure that some of you have heard stories of some women complaining that when they are in their menses, they bleed in their palms or they bleed in their
yes, I have heard that.
Navel and all. Yes, these are all endometriosis. So they are implanted as far as in your palms or in your navel area or umbilical area and all that. And so you experience those excruciating pains and bleeding and all that when you are menstruating. So that is how they come about. Now, in terms of managing and control, remember, once the woman has not gone into menopause and is still menstruating, it means that there's no way we are going to stop or cure this condition. So what we do is that when the woman comes to the consulting room, you will take history and then you ask about the woman's fertility or her wish or her desire for fertility. So based on what they want, now you can have a plan for them. So this is going to be on individual basis, because if someone is planning, let's say, pregnancy in the next 10 years or 20 years, and he has this condition, which if it's not managed, will also lead to infertility in the next 20 years or 10 years, that should be ready to get pregnant, then we are in trouble. So the management really depends on the fertility wish of your client or your patient or the woman in specific that you are dealing with. So most of these conditions are controlled by what we call hormonal pills or oral contraceptive pills. They come in different forms, and also with what we call the NSAIDs, that are painkillers, certain class of painkillers that we give to stop the production of the prostaglandins, which causes the pain. Now, in treating the endometriosis, in order, because we say that it's when you are menstruating, that is where the whole system or every place that these cells have been planted also menstruate. And so in order to be able to relieve our patients from their pain and also to achieve what we call a remission, I mean, that's a long-term relief, it means that then we have to stop the woman from menstruating. And so in this instance, we will have to give or put you in a medical treatment regime. Sometimes 6 months, sometimes 4 months, depending on the woman's wish and how she wants it to be managed. So there are some women that they are afraid that, hey, if I don't menstruate for 6 months, when something happens, you will give them all the assurances, yet they may be worried. So you can have what we call intermittent menses or continuous regime. So some women, you may put them on the drugs and allow them to menstruate, let's say, once every 3 months or once every 6 months or twice every year or something of that sort. So that psychologically.
Okay, Doc, and let me cut you in there. Talking about this menstruation and where you have to, put them on the pills, and I mean, when one is not menstruating, does it allow one to ovulate? Because I know it's after menstruation that ovulation sets in.
Okay. Yes. So there are two conditions, or that is, if you are talking about ovulation without menstruating. Now, assuming that there are certain women who are not ovulating and they are not menstruating. There are certain women who are menstruating but they are not ovulating. So in this case, yes, you can ovulate all right without menstruating, or somebody may also menstruate without ovulating, and that is when they are on their own. But with this particular instance, you are talking about if we put you on the medication, isn't it?
Doc, please go ahead.
Yes. So when we put you on the medication, we are going to stop that whole process of ovulating and then menstruating, so that you will be relieved, and all those scars and tissues that have grown will go what we call regress, which means that they will grow back to reduce size, yes, so that you will get that sort of relief. And so based on the woman's wish, her own perception, and how they feel about it, you modify their treatment regime to suit their individual demand. And so that is what we do. And it is very important that this condition is identified and treated early. If not, a lot of women, I said that 70% of women who have this condition have infertility issues. And so you have to take it very serious. I'm sure you have a friend, I'm sure you know somebody who has been complaining about severe menstrual pains and not able to go to school. They take time off work and affect their daily routine activities. And so that is it. Now, apart from putting them on the medication, there are some who develop what we call deep endometriosis, that even the treatment alone is not enough, and therefore they have to undergo surgery. Okay. So in the surgery, there are two forms of surgery that can be done for you. So they have what we call the laparoscopic surgery, where the keyhole surgery is done, and instruments are inserted, and you need a highly skilled gynecologist to be able to do that, because even some places they don't have the machine, so the doctors are not trained with it, so there's no way they're going to use that. Yes. And then we have the open laparotomy, where they open you up and go in and try and do something. And maybe I will share one story with you. I remember when I returned to Ghana, one of my colleague doctors in a different hospital, I received a call, and he said a relative has been complaining of severe pain, and goes some places and they say it's fibroids and what have you and all that. And so he wanted me to attend to that woman. Now I saw the woman, I took a scan and all that, and I realized that what they saw as fibroid was not actually fibroid, but a huge endometrioma, or what we call endometriotic cyst, that was between the rectum and the uterus. And so this woman has been complaining of chronic pelvic pain and back pain for how many years? And they've been given all sort of treatment, from herbal to orthodox medication and all manner of places that she has been to. Now, when I prepared this patient for surgery, sure, she was afraid of the surgery. And you know, in our settings, a lot of people are very religious and kind of, yes. So she had gone to see her pastor concerning the surgery, and they have had a prayer. So I was there a day before the surgery. She came to me that, well, the pastor said that if she take the surgery, she will die. So she's not preparing to do the surgery. So I canceled her, and I let her go. And I said that any day that she'll be ready, she should come. I think after 3 weeks, the pain became so severe that she couldn't bear. So she reported to me again. And I booked her, I scheduled her for surgery. Then the day before the surgery, she comes again. That she went for a prayer with the pastor, and she has passed stool, huge volumes of stool, blood. And so she believes that whatever the disease is,
the thing had come to pass.
The thing has come to pass, and so she's fine. Then I said, well, that is fine. But when she told me that, I knew what it was. Because you remember, I said that the endometriosis can be seated on the rectum.
Yeah.
And so it can cause this painful defecation and bloody stools. And that was what was happening to her. So she had diarrhea with bloody stool, and when she passed all that, she thought that she has passed the thing. So eventually, she agreed to do the surgery. And then when we went in, I mean, the whole pelvis was frozen with huge endometriosis. We removed the majority of them, and ever since then, she has been relieved. I mean, she's fine now. I think for the past 3 years or so, she's doing very well. And so these conditions are real, and a lot of people are suffering, but it's being misdiagnosed. And so if you have anybody with complaints of pelvic pain, and mostly associated with menses, you should be thinking that most likely it is endometriosis. Yeah. So at this point, I will pause for questions and any other things that may come out, and then we can continue.
Okay, so I would want to come up with the very first question. You made mention of menopause, that once you are still menstruating, then this process goes on. Is it not like fibroids where at any age you can have it? So that when it means that when you are, in your menopause, then you are free from this, issue.
Yes. So what it is that because this has to do with the menstrual cycle, the moment you cease menstruating, it means that the endometriosis will come down. Now, the only problem is that if you have developed an endometriotic cyst, the cyst is not going to regress and go anywhere. And because we also said that because the endometriosis causes inflammation and causes severe pelvic adhesion, then if this adhesion has been formed and the scars are there, even if you stop menstruating, the only thing is that you will not have that monthly menstrual pain, but the chronic pelvic pain will continue to be there unless it is treated.
Okay. Yeah. Right. Okay, Cynthia, you can unmute yourself and put your submission across. I see your hand up. Cynthia, can you hear me? Okay. So wonderful people, you are on the CS show, and today we are discussing endometriosis with Dr. Randolph Baah Edu. He has given a lot of information out there. If you just joined us, okay, I think Cynthia has unmuted. Cynthia, go ahead with the submission.
Hello.
Yes, we can hear you.
Cynthia.
Okay, thank you very much, Doctor, for the education. I want to find out, please, apart from the causes, I had retrograde menstruation. Apart from that, do you have other risk factors that can predispose the woman to endometriosis?
Okay, thank you. So, yes, there are risk factors. And apart from the retrograde menstruation, there are other theories, but that are more of scientific, and that's why I didn't bring them in, because this is more of education program. But one of the other risk factors is family history. So if your mother had endometriosis, your sister had endometriosis, or your aunties or your great grandmother, then you have high chance of developing endometriosis. And then one other thing also is, because we say that it only happens in women who are menstruating, it means that before menstruation, you cannot have endometriosis. And so those who also have early menarche, especially those meaning that they start menstruating very early, from the age of 9, 10, thereabouts, 11, 9, 10, and we start early, it means that you also have high chance of developing endometriosis. So these are some of the risk factors. There are others which are more of genetics and others.
Okay, thank you.
Okay, so Rita Udo, your hand is up, please. Unmute yourself and put your submission across.
Okay, thank you very much for this. I wanted to find out what happens after the surgery. Does it mean that a person becomes free of it?
Thank you. So you can never become free of it, but you can have a long remission. For example, if the surgery, they were able to incise or excise all, meaning that they were able to cut and remove all the growths, that the endometrial tissues that were there. And then also after that, they will have to put you on treatment. The oral hormonal drugs that we talk about, there are a couple of them, but I just mentioned the contraceptive pills, but the other hormonal ones. So they will have to put you on that one for a long time in order to make sure that they don't go back, so that you can get a long relief. And then based on that, fertility issues and all those other matters can be planned as a holistic approach in giving care.
I
so
see.
There are patients who have undergone 2 or 3 endoscopy surgery for deep endometriosis.
Okay.
Yeah.
Right, Doc, I also want to find out, it has to also do with the ovaries. It can happen on the ovaries. Is it the same as ovarian cyst or ovarian tumor or cancer? Is it the same thing we are talking about here?
Okay, so you can have, it can cause a couple of them. So the ovarian cyst, as you will hear, when the cyst, the tumor, and all that, they all happen on the ovaries. Now, we say a cyst when, depending on the size and the content of it. So the endometriosis can also cause what we call endometritic ovarian cyst.
Okay.
What it means is that there will be, that is why I said it's called chocolate cyst. So there will be a cyst on the ovary, and sometimes it takes all of us. When you open it, you see this chocolate, and it's like you open a toffee that contains chocolate, you know.
Right.
So you can develop, the cyst is just the name, but it can be different types of cyst. So you can have endometriotic cyst, you can have endometrioma, you can have follicular cyst, you can have functional cyst, and all that. And then they have the ovarian tumors. The tumors, majority of them are benign, but they are huge. And so they call it complex masses of the ovary. So those are cystic complex masses. So the tumors, some of them can be cancer, some are not cancer. So that is what it is.
Okay, so can someone have this predicament or this disease and also at the same time have fibroids? Can the two happen at the same time?
Yes, it happens at the same time, and we've seen a couple of them. Actually, it's a common thing. It's common.
Okay. Okay.
And so you realize that then the condition becomes worse.
Okay, right. Elizabeth, your hand is up. Please unmute yourself and put your submission up.
Thank you. Doc, please, I want to ask that I learned there are complications of endometriosis that can be life-threatening. So I don't know if you can tell us these complications that can be life-threatening.
Okay, so as we discussed, that it can lead to infertility. And one of them is ectopic. So endometriosis can lead to ectopic. Okay, and if you have ectopic pregnancy and it's ruptured, that is life-threatening. If you are not in a place that you can easily and fast be diagnosed and surgery is performed for you, by the time they rush you from a certain village to a hospital and you have a ruptured ectopic, or if they delayed at home, and they thought that, oh, it's some ulcer or some parabimano, and let's see how it will go. By the time you get to hospital, you will be gone. And also, we have what we call endometrial cancer, but that one is a bit different from the endometriosis. So, but it's the same tissue, but this one, it happens inside the endometrium, and then it can spread into other parts of the body, especially in the intestine, into the liver, into the stomach, and all that. And all these conditions, if they are not managed, can be deadly.
Okay, so Doc, somebody wants to know if you have this condition. If a woman has this condition, is she in the position to have a baby? And if yes, what are the complications that comes with the pregnancy?
Okay, so it can yes, you have a chance depending on the stage and how severe the disease is and whether it has been well managed or not. Right. So yes, there's always a chance to get pregnant. And one of the complications associated with this is miscarriages. Miscarriage.
Okay, right. So Rita, your hand is up. Please unmute and put your submission across.
Okay, Doc, I wanted to ask this question, and this is a bit personal. So I've had endometriosis and I had a laparoscopic surgery. So after the surgery, I was put on Lipron for 6 months. And after 6 months on Lipron, I came back having my menstrual cycle. But after 2 years, I began having severe pain, and now my my menses are irregular. It looks like every day I'm kind of flowing. So what is the chances? I've been to the hospital and I'm not really getting any answers. What am I? And the other thing too is I'm trying to conceive, which is also at the other side, but I'm having my menses almost every single day. So what can be done? What are the chances for me?
Okay. So what it means is that after the surgery and they put you on the Ripron, you had the relief, because I'm sure when you were on the Ripron, you were not menstruating, were you?
No, I wasn't.
Yes. So that one will get you the remission and the relief. And as soon as you stop using the Lupron and your menses, you started menstruating again, some of the endometriosis started going back. That's how come you have the pain. Now, with regards to the irregular menses, are you saying that you are bleeding now continuously every day? For how long now?
Oh, so from last year. So it can sometimes cut and I can have my menses, but these days I can't track it. It can just come and leave, and it's very irregular. And I can be flowing the whole month. Sometimes the quantity might be less, but sometimes it can be severe. I keep having that a lot.
Okay. So when there is another condition that is also part of the endometriosis, and it is called adenomyosis. I'm sure maybe you've heard about it. Adenomyosis. Yeah. In this case, the endometrial tissue, instead of implanting outside the endometrial womb, it actually goes deep into the uterine muscle and forms the adenomyosis. And when that happens, you have this irregular bleeding and continuous bleeding. So I suspect that it could be adenomyosis, or there is some form of maybe endometrial polyp or cervical polyp, or even endometrial or submucosal fibroid. So now what you need is to visit your physician. They will have to do a scan. Probably they will need to do a hysteroscopy for you to look inside the womb and see whether there is a polyp, adenomyosis, or fibroids there. And then after that, since you are trying to get pregnant, then you need to see the fertility specialist to plan your fertility. I'm sure probably you will need to undergo ovulation induction and assisted reproduction help. So what you are experiencing now actually is called abnormal uterine bleeding. So it's abnormal uterine bleeding due to either adenomyosis of endometrial polyp or submucosal fibroid. So you need to be investigated. They have to do ultrasound and also a hysteroscopy.
Okay, doctor. Thank you very much.
You are most welcome.
Okay, so wonderful audience. If you have any concerns whatsoever, Doc is here to address them. Do not take them back home. Put them across and he will do justice to them. You are on the Seer Show, a proud initiative by Prophetess Rhoda Anna of Manifestation of Holiness. We meet here for Mondays to Fridays for our morning raw or midnight raw, 12 a.m. US time, 4 a.m. Ghana time, 5 a.m. UK time, 6 a.m. Europe time, 7 a.m. Lebanon time, and 1 p.m. Japan time. We also meet on Mondays, Thursdays, and Fridays for our Zion Hour and Time with the Word of God, respectively. And the time is 12 p.m. US time, 4 p.m. Ghana time, 5 p.m. UK time, 6 p.m. Europe time, 7 p.m. Lebanon time, and 1 a.m. Japan time. So if you want to fellowship with us, you are warmly welcome to do so. This program is also proudly sponsored by Sante Mineral Water. You can locate them in Kumasi, Pankwane. If you happen to find yourself there, then Sante is the best that I would want to recommend to you. They say water is life. Jerry G Hats and Accessories, you can also locate them in Soweto, and they are also found on Facebook, Jerry G Hats and Accessories. So my guest today is Dr. Baah Randolph Edu, and he is the senior gynae at SDA Hospital Quadra. So if you happen to visit Kumasi and you have any gynae issues, walk in there and he will gladly assist you. If there are any questions, please, you can put them across. Right, so my name is Paulina and I am the host for the CS show. Doc, is there anything you would want to say again before we take leave of you?
Yes, I just want to say thank you for the opportunity and thank your audience for listening and also asking the questions which made us possible to share ideas and the experience. One of your listeners actually share her own experience of undergoing laparoscopic surgery and treatment and all that as we discussed. And so I'm grateful. Thank you very much.
Okay, so before Dr. Randolph goes, somebody requested for his number. I am going to put my number across, and then please you contact me, and then we will take it from there. So my number is, you can get me on WhatsApp, 020-73-22673. So you contact me, and then I will direct you, or I will help you get to Doctor. Thank you so much, Doctor. Doctor happens to be my schoolmate, and you know he has never denied me anytime I have to call on him. And
a pleasure.
so your colleague, Dr. Sasha, says he wants to say hi to you. And Dr. Sasha, you are welcome to the CS show. It's amazing to have you. I want to say a very big thank you to all Nananom 98-year group for supporting this cause. You have always been there. I want to thank my family, my friends. I want to thank.
I have something to ask Doctor, please.
Please do, Dr. Sasha. Go ahead.
Start off to Sasha.
Yeah. Please, your friend say maybe. I say when I lose a crowd, meaning what on association as on the day.
Who after delivery?
There be no.
Okay, so we have something we call Kegel exercise.
Yeah.
Yes. So she can start with the Kegel exercise to strengthen the pelvic muscle, and then things will get in order. So you can start with that one. But in social, there is no good.
I can't hear.
I'm saying
Dr.
that.
Randolph,
Yes.
What you mentioned, you know, how do we do it? Is this something that she would have to visit the hospital, or something she can do, you know, on her own at home?
It's something she can do on her own. Now let me explain simple how it is like. It's like when you have the strong urge to urinate, okay, and then you've not reached a comfortable place, so you squeeze
it's in the hole.
your gluteus muscle.
Okay.
So
expansion and contraction like that.
Yes. So you contract your gluteus muscles and relax it. You contract it and relax it. So there are certain ladies who have trained themselves and they are very good at it. And so during intercourse, when they do that, the men think that something is catching their something. So yeah, it's one of the best things for pelvic floor muscles training. And all women who have vaginal deliveries and stuff like that, if they can practice it, and it will improve.
It makes it tight. That's good. Cynthia's hand is up. Cynthia, please unmute yourself. Our midwife on the platform. Please unmute yourself and put your submission.
Yes, I wanted to tell Dr. Sasha that she should let the wife see her midwife for that Kegel exercise, so that we'll train her very well. Okay.
Right.
Okay.
Yeah.
Thank you so much. Thank you, Doctor. So finally, your very last words before we go.
Thank you all. It's a pleasure being with you. I'm most grateful.
Right. It's been wonderful having you for these couple of weeks. We love you so
Paulina,
much.
please. Listen. I did not hear.
Okay, so
I did
you will
not hear.
see me in chambers, and then we'll have a conference call and talk about it. Okay. So
Okay,
this
but
is
okay,
what time.
but wait. Someone is saying maybe I need to get my dick enlarged. Is that something doctor knows about?
You see, the problem is the girls are trying to get the vagina smaller, and the guys are trying to get the penis big.
Bigger.
So where are you going to put the big penis if the vagina is getting smaller?
But I want to get it to my size.
Right. We will definitely have a conference call, to that effect. And okay, so
No.
it looks like we are not going now. So Michael Bamford, your hand is up. Please unmute yourself and put your submission across. Prof, don't go. Doc, don't go.
Okay.
Thank you very much. I want to know we discussed the topic we discussed. Cancerous.
That wasn't clear. Can you please come again?
I think he wanted to know if the topic we discussed cancer.
Okay, Doc, if you heard him right, then please.
Yeah. No, it is not. It is not cancerous. Endometriosis is not cancerous. So it is not about cancer. No. We have what we call endometrial cancer. That one is different on its own, but endometriosis is not cancerous.
All right. Thank you very much.
Okay. Thank you.
Okay, so on that note, this is what time would allow us. Thank you so much, wonderful audience, for coming. Next week is going to be fireworks. Please invite family and friends to come and benefit from what you have just received. Okay. I want you to take very good care of you. Next week is bye-bye.
Bye.